The use of muscle relaxants in intubation, operating room, and ICU management. Welcome to Medical Specialist Associates' educational series on topics in anesthesiology and critical care medicine. I'm Christopher Voss, MD, MS, FCCP, board certified in anesthesiology, critical care medicine, and neurocritical care medicine. Today, we're going to explore the use of muscle relaxants in various clinical settings, from intubation to operating room management and critical care in the ICU. Muscle relaxants, also known as neuromuscular blocking agents, are essential in a variety of clinical situations, including facilitation of endotracheal intubation, surgical procedures requiring muscle relaxation, management of critically ill patients, such as those with acute respiratory distress syndrome, ARDS, to optimize mechanical ventilation and improve oxygenation. There are two primary classes of muscle relaxants. 1. Depolarizing agents, the most commonly known as succinylcholine. 2. Non-depolarizing agents. This class includes rocuronium, vecuronium, cisatracurium, and others. In the context of intubation, particularly rapid sequence intubation, RSI, muscle relaxants are essential to achieving rapid paralysis for safe endotracheal tube placement. Succinylcholine is often used for RSI due to its rapid onset and short duration of action. It acts by mimicking acetylcholine at the neuromuscular junction, leading to sustained depolarization and paralysis. Advantages: quick onset, 30 to 60 seconds, short duration, 5 to 10 minutes. Risks: can cause hyperkalemia, malignant hyperthermia, and bradycardia in certain patients. Rocuronium, however, is by far the most common muscle relaxant used in the operating room and is a non-depolarizing alternative for RSI, especially when succinylcholine is contraindicated in patients with hyperkalemia, a history of malignant hyperthermia, or burns. In terms of RSI, rocuronium is comparable to succinylcholine in terms of onset, but a higher dose is required to achieve the same rapid onset. Advantages: fast onset, 1 to 2 minutes, longer duration than succinylcholine. Important consideration: when using such high doses of rocuronium for rapid onset, Sugammadex should be readily available for reversal if necessary. Sugammadex directly binds rocuronium molecules and provides rapid, reliable reversal. In RSI, the use of muscle relaxants in combination with sedatives, such as etomidate or propofol, ensures patient comfort and prevents awareness during the procedure. During surgery, muscle relaxation is critical for procedures requiring immobility or for accessing body cavities. The choice of muscle relaxant in the operating room depends on the duration of the procedure, patient-specific factors, and the need for reversibility. Rocuronium. As mentioned, rocuronium is one of the most commonly used agents due to its fast onset, intermediate duration, and reliable reversal with Sugammadex. It's widely preferred in many settings. Cisatracurium, a non-depolarizing agent frequently used for its predictable metabolism independent of liver and kidney function, Hofmann elimination. Advantages: ideal for patients with hepatic or renal impairment, predictable duration, minimal side effects. Common use: general surgeries requiring prolonged relaxation. Vecuronium, another non-depolarizing agent with an intermediate duration of action, 45 to 60 minutes. It is commonly used when a longer duration of paralysis is needed. Advantages: fewer cardiovascular side effects compared to other agents. This may not be widely known, but it's an important factor to consider for patients with cardiovascular instability. Consideration: requires hepatic metabolism, so caution is advised in patients with liver dysfunction. The choice between these agents also depends on the availability of neuromuscular reversal agents such as neostigmine or newer agents like Sugammadex, which provides rapid and effective reversal of rocuronium and vecuronium. While neostigmine is a commonly used reversal agent for non-depolarizing muscle relaxants, it is important to administer glycopyrrolate alongside it. This combination is critical for protecting the heart from bradycardia and potentially dangerous arrhythmias, including asystole. Why is this necessary? Neostigmine works by increasing acetylcholine levels at the neuromuscular junction, which not only reverses the effects of muscle relaxants, but also stimulates the parasympathetic nervous system. This can lead to bradycardia, a dangerously slow heart rate, or even asystole, absence of a heartbeat, particularly in patients with a heightened vagal tone. Glycopyrrolate, an anticholinergic agent, counteracts this parasympathetic effect by blocking acetylcholine receptors in the heart, thereby reducing the risk of bradycardia and ensuring cardiovascular stability during the reversal process. The combined use of neostigmine and glycopyrrolate is standard practice to minimize these risks and ensure patient safety. In critically ill patients, particularly those with ARDS, muscle relaxants are used to improve oxygenation and optimize mechanical ventilation. Cisatracurium is the preferred agent in the ICU for patients with ARDS due to its metabolism by Hoffmann elimination, predictable pharmacokinetics, and minimal side effects. Use in ARDS. Studies have shown that short-term use of neuromuscular blockade in the early stages of moderate to severe ARDS can improve oxygenation, decrease ventilator-induced lung injury, and improve overall outcomes. However, prolonged use of muscle relaxants in the ICU is associated with risks. Prolonged neuromuscular weakness, which can lead to ICU-acquired weakness and complicate recovery. Immune suppression and increased risk of infections. Therefore, in the ICU setting, muscle relaxants should be used judiciously and for short durations, ideally in the early stages of ARDS or during acute episodes when oxygenation is critical. Throughout any procedure involving muscle relaxants, proper monitoring of neuromuscular function is essential to ensure patient safety and avoid prolonged paralysis. Train of 4, TOF monitoring. Used to assess the degree of neuromuscular blockade by delivering 4 electrical stimuli and observing the muscle's response. A train of 4 ratio of 0.9 or greater is considered sufficient for safe extubation. The 2023 ASA guidelines emphasize the use of quantitative train of 4 monitoring over qualitative methods for more precise assessment of neuromuscular function. These guidelines also stress the use of sugamadex as the preferred reversal agent for non-depolarizing agents like rocuronium and vecuronium. Although this is a focus in operating room management, it is likely that these advancements will also extend to ICU practices in the future. In conclusion, muscle relaxants are indispensable tools in clinical practice, from intubation and surgical procedures to the management of critically ill patients in the ICU. Proper selection of the appropriate muscle relaxant, careful monitoring, and timely reversal are crucial to ensuring the best patient outcomes. Additionally, as clinical guidelines evolve, such as the ASA's 2023 focus on quantitative train of 4 monitoring and the preference for sugamadex, it is important to stay informed on best practices. These advancements in neuromuscular monitoring and reversal are likely to improve patient safety and outcomes, not just in the OR but also in critical care settings like the ICU. To learn more about anesthesiology and critical care medicine, please visit us on our website at medspecialists.net and subscribe to our YouTube channel.